All right, it is noon central, so we are going to get going here. Thanks everybody for joining us today. We have a really good webinar for you today. Is charge capture audit really necessary? I'm guessing you probably know the answer we're going to give on that, but we're going to walk through it, and there's a lot of great content to share. As usual, everybody is on mute, so there is no background noise from anybody, but we will be taking live Q&A today. And so if you have questions, please submit those through the Q&A panel. That is the best way to keep us organized and make sure that we do get to your answer or your question so that we can answer it. With that said, today's webinar is presented by William, aka Bill Malm, and he heads up our charge integrity team here at Vitalware. Bill, hand it right to you.
Well, thank you all for joining. It's a pleasure to be here, and I appreciate your time on this topic. This is a topic kind of near and dear to my heart. I have 25 years of audit experience, and auditing is something that's frequently overlooked as a preventative methodology to prevent charge capture leakage. So we're going to go through first of all, the disclaimer about it was published or provided by the web, it's accurate to today's date. And also, if I mention CPT codes or revenue codes, they are copyrighted by the AMA and AHA respectively. Our agenda today is to go through just a quick overview of charge capture basics, how to identify charge leakage, the benefits of an audit program, how to design one, and then do you need software? Our objectives is just obviously to understand the charge capture process, and it's going to be at a high level. Every single charge capture process I've seen has all of these elements, but you as a facility are like a fingerprint. You implement them in a slightly different way. So we're going to try to talk to that. Where to look for charge leakage potential, and sometimes it's in the most mundane of places. How to do random audits and why they're important. How to create an audit. It's more than just the OIG work plan. It's creating an audit for your department to make sure you're not losing revenue, and understand when software can help. So I want to start off with an Einstein quote today, that no problem can be solved from the same level of consciousness that created it. Basically, the charge capture process has a problem in it, and you can't solve it by using the same method you did to create it. And that's what I see over and over and over again in our audit, is we're trying to use the same method and trying to make it work the way it is, and it's changed in some way. So we have to kind of open our mind to the fact that it's going to be different. So when we look at charge capture, there's a flow portion. The blue section is really clinician involvement and documentation. Before you can enter the charges starting in the purple section, you have to have all documentation present. And that is kind of a CMS rule, it's a payer rule, and there are reasons why there are flaws in this first four boxes that carry through all the way to the claim and why it's denied. You enter the charges either automatically or through another methodology. It goes over the CDM to be hard-coded or assign a level charge, and that is charge leakage spot number 1. That is a true issue in most facilities. It goes through pre-billing edits, claim generation, and then over to the payer after scrub, and you get reimbursed. So the bottom line here is there's two failure sites. When we're looking for the weakest link, the blue section, and then the CDM section and the charge entry section. So as we move to the next slide, there's always a question, and I've been, kind of in this industry for a while. Well, what can I charge for? There are 5 buckets of things that you can charge for, no matter what the payer is or what have you. So you can charge for procedures. These are usually surgical in nature, and they come in the CPT code range of 10,000 through 6,999. You can charge for services such as lab, radiology, medical procedures, E&M. They're in CPT code 70,000 for radiology, 80,000 for lab, 90,000 for medical procedures and E&M. You can charge for pharmaceuticals direct to the patient by revenue code, and supplies that are separately identifiable to the patient. generally when we're talking supplies, we're not going to go after the Band-Aid or the admission kit or the some sort of thing that's provided to all patients through every experience at the facility. Those go in the room and board price or the procedure price or something like that. So if you're setting a room up for an angiogram and you've got sheets on the bed and a disposable pillow and a cover for the angiogram on the x-ray machine and gowns, gloves, drapes, things like that, you don't bill that because it's in the price of the procedure. So it's not separately billed, but it is billed, but the price is included in the procedure. The bottom line here is that in all cases, the CDM must contain a line item for these charges. If there's no line item, there's no capability of charging it. And that's where I find a lot of issues with the CDM, in that a facility department will start a specific process or service, and they're not clear with the CDM team, so you may be missing charges. Alternatively, on the other side, they may have gotten rid of equipment, they can no longer do those services, and they're still in the CDM. So CDM represents a risk area. So when we look at the overview, we talked about documentation and charge master, but the assignment of charges is really quite different depending on the facility, even within the department. So some people are still on paper. Some doctors' offices that submit charges are still on paper or charge slips, some clinics. Others on order entry, manual system charging through a Meditech or a Cerner. Others are documentation driven, meaning respiratory therapy does an aerosol, they document the aerosol, it's charged out. And then because of all these different complicated methods, there has to be a daily charge reconciliation. What did we do? And then random reviews to make sure it's working. Daily charge reconciliation has erroneous periods that need to be, why we need to do daily. Shift change is a known cause of charge leakage. So for example, the nurse started an IV in the ER. It is 80% complete. The new nurse comes on and they forget to put a stop time because the prior nurse started the start time, so there was nothing triggering them. Shift change is a big problem. All right, so what is documentation? From the Office of Inspector General, they say proper documentation in both the patient's medical record and in the claims is important for 3 reasons. It protects the program, and by the programs I mean Medicare, Medicaid, and federally funded program, protects your patients, and protects the provider. If your records do not justify the items or services for which you were billed, you may have to pay that money back. And I want to also point out, this goes beyond federal funding. This type of issue appears in most litigation, malpractice litigation, where they will have a auditor go through every single order, every single claim, and make sure there's documentation for all the services. So this is important from a litigious standpoint and from a quality standpoint. If I forget to say that I put the splint on and I don't charge for it, and the patient gets the splint and goes home and the splint is too tight, nobody knows about it. So it's a quality issue. Documentation best practice is to have the documentation present in the record prior to assessing the charge. And that's where we saw the 4 blue boxes going into the purple. So unless all the 4 blues are complete, you shouldn't be in the purple area. Documentation accruing through the EMR, however, charging may or may not be driven through the documentation in the EMR. And this is a touch point that informatics forgets about a lot. They write great documentation, but then we don't connect it to charges, or we don't keep it the maintenance on it. So a charge master, again, the OIG is going to speak up. They say the list of possible charges for items and services include the underlying procedure codes necessary for bill. Outdated CDM create a significant compliance risk. So look at the date of this. This is 2005. So this is basically 15 years ago where this came out, and still I see CDMs that are not updated and proper use of modifiers and things like that. So this is where charge capture has to step in. So there are 2 types in the CDM. One is hard-coded, and those are the things that are done just despite which patient, what setting, there's lack of a variability. An EKG in the ED is the same as EKG in the cardiac cath lab is the same as EKG in an outpatient department. Because these lack variability, between patients, they can be hard-coded, meaning I can have a procedure that when complete can be linked to a charge, and that charge automatically charges through upon completion. Because it's hard-coded, there is an assumption that all the documentation is present. So if you get a verbal order for a chest x-ray and you forget to write the verbal order and the chest x-ray performed because you called over to radiology and they came and did it, that is an area where documentation isn't present. So we want to look at that. The method for charging is the least advantageous is paper, charge slips and downtime charging. System charging through order entry or through a human intervention also leaves room for charging the wrong charge or forgetting to charge or overcharging. Documentation-driven charging, now that we've moved ahead with EMRs and systems and informatics, this tends to be the new benchmark for the industry. Informatics takes the actions performed by nurses and physicians and attaches a charge based on the specifics. So if they document that they gave the aerosol or they completed the chest x-ray tube view and on leave department they complete that exam, it will charge the x-ray tube view. Ensures this piece, by doing this, all documentation has to be present or it doesn't charge. So that's a good thing. So documentation driven is especially suited for all the hard-coded CDM items. Other documentation are templates that ensure the information is present to allow HIM to code based on documentation. This would be your soft code. So there's an ER level for lacerations, simple and complex. And you have to have templates that are going to allow HIM, and you work with HIM to come up with a template to get all the necessary documentation to be able to create that charge. That charge generally is then coded by HIM, but HIM needs to know the length, the depth, the location, all of that. And frequently, because this is buried within a narrative or a long procedure note or a long docs note, HIM gets busy and they miss it. So templating your procedures is really the way to go. And doc orders up a suture tray, and a suture template comes up, and it has the nursing notes, has the doc notes. They complete that template, and then the level goes through. Pick lists and preference cards also auto charge, but they do something completely different. They charge the entire preference card except for what you say you didn't use. So when we do audits of the OR, we see a significant source of incorrect charges. They either use something in lieu of it, they forgot to charge the in lieu and credit this, or the whole thing is put out there and they didn't in fact use it. So these are all issues in charge capture. Pharmacy charging is pretty tight. It's either at dispensing or at administration or through a Pyxis or supply cabinet. So it's pretty tight. There's usually no human error in this one because you have to scan the patient, scan the order, scan your badge, scan the patient, scan the drug. There's like 5 steps. However, where the issue does occur is in the CDM, taking the dispensed units and moving it over to the billable units. And I will tell you, in 100% of the charge masters, almost that high, probably 90% of the CDMs I've reviewed manually, I have found money in pharmacy because the billable units are not, that calculation is not correct. Or they used a different NDC that had a different package size that created a different billable unit. So the billable unit calculation is the issue, not the dispensing. Charge reconciliation should be performed daily by department, and your system should have sort of charge reconciliation. However, if they're like me, I got a lot of patient care. I've got 14 patients I've got to write notes on before I leave tonight, and I totally forget to do my order reconciliation. It's time sensitive, so if I'm off for 4 days and I come back, those charges already went out. And charge reconciliation is seldom part of a policy or procedure, and if it is, it doesn't have enforceable outcomes. So that's an opportunity for everybody. Usually it's cumbersome. It's not user-friendly. Late charges are in every facility. They're frequently claims sent back from HIM to add charges or delete charges. Difficult to manually perform without software. Reconciliation is necessary to avoid these losses through hard-coded charges or soft-coded charges. And reconciliation is necessary to ensure soft-coded are in fact charges not coded. So what generally happens is a revenue integrity person will randomly select a record and go through it and find out how it's working and see any possibility of leakage. So we've talked about kind of all the bad things that can happen, and we're not trying to do doom and gloom. We want to show you where all these things are potentials, and you want to identify the weak link through an audit program. So before you can define an auditor, you need to know what the audit is, and it's an official examination and verification of accounts and records, especially financial accounts. I am a certified auditor. I was trained on the finance side and then on the medical audit specialist side. It is the same exact methodology. That's the point. An audit's an examination against a defined control point, whether I'm in finance, whether I'm in medication reconciliation, whether I'm in nursing service reconciliation. It is a process against a defined control point. So the process will be the same, and I'm going to show it to you. The purpose of audits, according to the Medicaid Integrity Manual, is to provider claims and identify overpayments by ensuring the claims are paid for items and services provided and properly documented. So there again, we go to provided and properly documented. What is proper documentation? A physician order, documentation the service was provided, and then the charge. Before the order and the documentation of service provided, you cannot do those. You cannot put in the charge until that occurs. So what is this auditor? And unfortunately, revenue integrity auditors are not yet at a point where I can go into every single institution and know what their skill set is and how they've evolved through time and how the program works. Some are very, very, very articulate and have internal auditors as part of it. Some are more novel at revenue integrity, and we're just looking for overcharges. We're not looking for patterns of detection. We're not using types of data analytics. But they're usually known for financial examinations, and they employ that in. So it could be CPAs, it could be attorneys, but the revenue integrity people follow that same methodology. They usually have a specialty in chart reviews, so they can be clinical or coders, but it's not necessary. They just have a working knowledge of medical terminology, what that process is, and then what the CPT code is, and putting those pieces together. Utilizes a benchmark auditing technique similar to finance and established audit. So what does it look like? And I'm going to show you audit cycles from different groups and show them they're the same. In this one, we identify a topic, set a standard or design the method, collect the data, analyze the data against the standard, and implement any changes. In the next one, here's a nurse midwife prescribing audit. They set the standard, select the criteria, measure the performance against the criteria, make any improvements, and sustaining improvements is basically that re-audit phase. So it looks identically the same. The third one is setting the standards, measuring current practice, and this is quality control one and a finance one from National Health Service in the UK. So they use this on everything. So you set your standard, you measure your practice, you compare the results with the standards, you change your practice if they do not meet those results, and you re-audit. That last step, re-auditing, is the #1 reason audits fail. We fix it like most people know. We have a fire in our department. We go and we fix that thing and we're on to the next thing, but we never go and see if it really took. So 6 months later, we're having the same conversation around the same table saying, I don't understand it. We fixed this 6 months ago. So the key elements are the definitions, the written set of standards. What's that going to be? Do I have a policy like on the point system in the ED? Do I have a standard like as a CPT code for a procedure? Do I have an audit standard? What are the data elements? And am I going to get all of them, or am I selecting ones that I don't need? specific review elements against the standards. So for example, if I'm looking only at CPT, the diagnosis code is of no value to me. So what data elements represent the standard that I've set that I need to compare it against? Publishing the findings and then corrective action. It's the expectation that every audit follow those steps. So if a step requires an amendment, it must be noted as a variant in the report. And then you go back and you fix it and you re-audit for the variant. So here we go again, phase one, the standards. Phase two is the practice, and then selection must be flawless. So we're going to audit the universe of a population being examined, or are we just going to get a few records? Are they correct amount? Are they statistically significant? Do I need a statistical significance? Are you a hospital that is in Colorado that tends to be in the mountains and gets a lot more volume in the winter than in the summer? Or in Hilton Head, South Carolina, where the summer people come and you're going to get a lot more. So there's seasonal variability. Is there an audit for compliance that requires statistical reliability? So compliance says, I need you to do this audit, then they're going to have to tell you how to do it because there's statistics involved. What you're looking to do is see, is there a pattern of behavior here? Not, I found this thing happen one time, but you're looking for things that happen over and over and over again that require remediation. Will selection by software such as charge capture or claims that reviews 100%, or will be it by manual selection? And you can have one or both. So you might want to do an audit that's just by manual selection, and you follow it up with your daily charge audits with software. Or you have your daily charge audits with software and you find a pattern of behavior and you want to audit a subset of that. It can be any type of variation on it. The easiest method to employ is the nth method selection. So say you want to look at 100 records. You take the last digits of the month. So say you're October. That's 10, okay? So you're going to take every 10th one until you get 100 records done over 12 months. So you set your universe as being 12 months. I'm going to select every 10th one until I get to 100 records. If it's April, I'm going to select every 4th one. If it's February, every 2nd one. So just make it easy on yourself. The point here is to randomize it and not get, you know, just the summer people or the winter people skewing your results. So we compare the results against the standards. So for example, I'm auditing ED records and I have a point system. So first of all, the standard is the point system, the written documentation of the point systems. I will select randoms and section and compare them against the point system based on the documentation. So I basically will go through the document and recode that document using the point system that has been adopted by the facility. Another example is radiology exams to meet the medical necessity. Select a portion of exams that you know require medical necessity and randomize them to see if you got it. You know, FDG is one of them. You may have, you know, certain mammography may be one because there's a frequency. Randomize it. Compare like MRI against Medicare or payer guidelines to ensure documentation is achieved. If you have software, most of the charge capture audit is based on solid coding and medical necessity rules that include a variety of components, be it diagnosis, CPT, and they have a trigger and a target. And if the trigger's on the claim, it needs to have the target on the claim. If the target's not on the claim, the rule's going to fire and you're going to have to go research it. The advantage to software is the fact that it consumes 100% of your daily charges or 837 I's, which is impossible to do if in fact you are using manual. There is no human being that can run through every single charge, look at a target and a trigger and make sure that it's working. So software is now becoming the benchmark of the industry because of the data analytics component and the ability to quickly correct known issues or found issues. So we've gone through changing the practice. So when we're going to see the findings, when we compare the results. If there's no finding, if it's working fine, no action needed. But if it isn't fine, then I need to figure out what the aberrancy is, or are there multiple issues? And then I need to go back to the root cause and remediate those issues. And the goal is not to just continue and find some error over and over and over. We see this not so much with our clients, but when I was in the consulting business, the CFO wanted to know how much the charge capture stuff found, and they wanted to find more and more net every month. Well, the problem is the whole sole purpose of charge capture software is to eliminate the failures so that you actually reduce and improve your cash flow and cash Excel. So they're looking for you to repeat it over and over again. And the purpose behind charge capture software is actually the reverse, which is to find the errors, fix them, so you have improved cash flow and cash acceleration. If I'm going to remediate the findings or a pattern of behavior, I'm going to usually employ a Six Sigma team if one exists in your facility. If not, we're going to teach you in a minute a really simple way to do Six Sigma. Also, many certified auditors are Six Sigma trained and certified. So the courses I went through, I had to be Six Sigma and an auditor to get to that point. So a Six Sigma, very easy technique, if you see a pattern of behavior, is to ask the question why 5 times. So why is the finding there? You repeat it 5 times until you get your result. And you'll be surprised, the result usually is not what you thought it was. So here I have an example of a joint device implant, C1776. It's on the claim as the trigger, but there's no target procedure on the claim for a joint. So why is C1776 on the claim? Because it was charged from the OR by a preference card. Why was it charged if no procedure was documented? Because nursing used a pick list on the wrong patient. Why was the wrong patient assigned a pick list for surgery they didn't have? Because they had the same last name as another patient on the schedule that day. Why did this error occur? Because the nurse was between rooms as a circulator. Why can this happen with specific policies and procedures in place? Because the failure to use patient identification resulted in it, and the nurse needs new training. Now, obviously, when I looked at C1776 and said, yeah, I got a joint device, but no joint, I didn't think it was because of the nurse charging on this result. So when you look at these whys, you will be shocked. Okay, a lot of times I see charge capture, and when I get to the 5 whys, I get the last why, I find out that the nurse was a locum or a floater and had no idea to do it. And so these patterns happen, routinely over 3 or 4 days because they were assigned there. So what you're going to do is remediate the issue. Once the root cause is found, you have to fix it. So the corrective action plans are put in safe, and they fail because the staff focuses on that next fire, and you forget to go back and see if it took. Ensure the remediation is written so that step 5 is easily documented. There's a time and a place to do it, and regular audits for every 3 months or every 2 months to see if it worked and if you knew different changes. So I put in what I thought were strategically wonderful remediation plans that were catastrophic failures, because when I put that and compared it against the benchmark, the new benchmark, it didn't work as designed. Okay, so you do need to re-audit. So again, we're just going to keep showing you, but this step here, this re-auditing step, is the step that fails most often, and it is the step that causes the issue to continue. So we looked at the 5 steps, the type of chart being undertaken, the key elements of the audit cycle, establishing the standards, comparison against the standard, and the goal is to compare the record against those benchmarks. And the best way to do it is pre-bill or soon after the billing, like in 837. I mean, you don't want to really wait until it gets denied or you lose charges and have to rebill it. The average cost of a rebill, according to HFMA, 3 years ago was $35. So if your net investment doesn't come back equal to $35, then you don't rebill it. A lot of those added up is going to hurt your bottom line. So the industry benchmark is to use software. HFMA reports that 1 to 5% of the facility bottom line is due to lost charges. Okay, 1 to 5% of millions of dollars on your bottom line. This is not 1 to 5% of that charge. This is 1 to 5% of the bottom line. They also reported, interestingly enough, in 2019, that facilities only talk about charge capture less than once a month, and on average, it was every 5 months. So by not addressing it and keeping it in the forefront, you continue to make this almost a lack of a priority, and then a fire will happen, and then you'll go back to it, and that's not a sustainable process. So today we want to tighten up that charge capture through some sort of ongoing sustainable process. Industry benchmarks combine the real-time software reviews with daily charge reviews. So the industry is using software reviews and charge reviews. So if I find that C1776 is showing up, but it really was a typo and should have been C1726 in the CDM, that's a big difference. If I find that in my audits or in my daily charge capture, I can then put in a workflow back to the CDM and say, quick fix this and rebuild them. While software does perform a day-to-day, the need for in-depth focus audits continues and create a recertification plan. So how do you set it up? People ask me all day, Bill, how are you going to set up my audit plan here? Well, you can choose high dollar claims. You can use claims that are actually timing out. They're getting close to that time frame where final billing has to occur. You lose the opportunity to charge it. It can be based on late charges. It can be based on supply coding. So you did a CDM review when you found that 40% of your supplies are miscoded. Areas that are frequently failing the initial scrub. In your scrubber. High volume areas, radiology, operating service, ED, cardiology, oncology. Areas where charges are not driven by documentation, but by driven human methodology. So that would be oncology. Start and stop times. If you don't have pumps that are doing that and importing it in, your start and stop times may not be there for HIM to code it or another in department to code it. So that's very important, is that you understand where your data is going to come from. So you set the standard. With the Cath lab, for example, you're going to have hard-coded and soft-coded items. The hard coding is usually going to be the supplies and some of the basic stuff, maybe drugs, while the soft coding is usually HIM. It could be the department. It could be a Cath lab generated coding system. But you want to select your references. What's your benchmark going to be? It's going to be CPT. It's going to be Dr. Z coding knowledge, vital knowledge, device lookup, FDA information. Ensure that the rules within the software are based solely on source authority. So you didn't make up the source that, they always told me I should be looking for this. You need to have a source that you can go to and say, that's what I use for the standard. So that's a big thing. You measure your practice. So using one, I set up the standard. I looked at the catheter and devised HCPCS code 1726 is not being consistent with the transluminal angioplasty. And I had 50 of these when either in my manual review or my software review. So either the procedure is inaccurate or the supply is. The inconsistency needs further drill down. Is HIM coding it wrong every time, the procedure, or is the supply wrong? So review of the EMR finds that a TPA of the circumflex did occur, and the coding reflects those guidelines. So the procedure occurred correctly based on documentation. Now we know it's the supply, which is the trigger looking for a procedure. Well, C1726 is not the correct trigger. If you look at it, it is for a catheter balloon, non-vascular, and you're doing a vascular procedure. So you view the coding on that particular model is wrong. We know that it is an Evercross model, and we go to the payer guidelines, or we go to Medtronic that has their own method, their own guide for reimbursement. And I'll caution you, they're sometimes flawless and sometimes they're fraught with errors. If you have vital knowledge, you can go right there and look up your devices by just going over to VitalWare or your entity and selecting devices. And then you see that every single ever crossed balloon in the Cath lab is C1725, not C1726. So you change the practice. Because it should be 1725, you review the supply mapping to ensure the catheter's connected, review the CDM and see that the Evercross really has C1725 on it, and then you better review all catheters in that section to make sure they're moving forward, because it's already, you found one issue, is that going across all the Evercross balloons. You then remonitor. You using daily reviews, you see, did that stop triggering? Did that rule stop firing? It's like it's not happening. Or on my manual review, I don't see that being a problem anymore. So then you just keep monitoring that. But you've also identified that these types of catheters are very vendor dependent, and they have different C codes assigned to it. So you need to do with your yearly coding reviews, which I seldom see, is a complete review of your supply chain. Do I have the right codes on these things? Because very frequently, not only with CPT codes, but suppliers will update their coding at the beginning of the year. And if they get a new code, like a new device or a new drug, they'll get a quarterly release. But generally at the end of the year is their new information comes out. Here's another example, stress tests. So you set the standard. Coding guidelines suggest that radioisotopes and stress agents should be billed together. You have a trigger of 3 stress agents. If one of those presents on the claim, then I expect a stress test, a tracing. With software, I did a 100% review. And if I didn't do 100% and I did a manual, maybe I did 50 charts, and I said, you know, if I've got these J codes, do I have a stress test? I compare the results, and what I see is that aberrancy can occur. So I then start that 5 why again. Why is there not a charge in the Cath lab CDM? Because we're supposed to have an explode code. Why is there no explode code? Because compliance didn't want explode codes. Why wasn't an alternative method charging be established? Because the Cath lab didn't know they needed it, thought there was an explode code in place. Why did the Cath lab not know? Because communication failures between CDM compliance and the Cath lab. And this is silo management to its best. So hospitals will say, I can't do explode codes, or except for this and that. But the department doesn't know that. And they have an expectation when I do X, I'm going to automatically get Y. So you create the remediation process, and you document your coding standards against the net revenue loss. How many times did it happen, and what was your net revenue? Maybe in this case, you did an explode code, and then you monitor the results and do an nth randomization. I'd start with week 1. Did you fix it? Here's another one, and this one is an actual case. When I was consulting, I actually found this. We went in for the sole purpose of finding out why there was decreased revenue in some of their departments. And the ED manager came to me and stated there's a sudden decrease in revenue in the ED despite an upward trend in volume. The manager stated in the month of July they had a lot of acuity based on their staffing model, meaning their acuity was higher on their staffing model. They were able to show that through data analytics, and they were mostly level 4s and 5. That generates revenue. You shouldn't be losing revenue with an increased volume and higher levels. You don't employ concurrent software, so revenue integrity starts the nth level process. They set the standard, they used the point system, and they went ahead and did 100 records, and they looked at the median through revenue and usage level 1, 2, 3, 4, and 5 for the prior 6 months with revenue and usage. And what we found was 5% was level 1, 15% was level 2, 3 was 30%, 4 was 20%, and 5 was 30% in the benchmark period. However, in the current period, we see there's 100% for level 1 in July and absolutely nothing else, just 100% for level 1. There were no 2, 3, 4s, or 5s for the increased volume and increased acuity. So obviously something's gone wrong here that this has happened. When we did that result, we started to ask, why are all the E&Ms? Because the point system calculator assigned a 1. We went in and looked at the point system. Why did it assign a 1? Because the calculator was disrupted during an upgrade. Why was it disrupted? The vendor upgrade failed to fully complete. Why did the vendor upgrade fully complete? Because ED and IT failed to refresh it after the completion within the allotted time period. Why did ED and IT not refresh it? Because they didn't know they had to. So because of these charge capture issues and upgrades, and I will tell you, upgrades and patches are fraught with errors, fraught with them. They fix the software, but they frequently disrupt your charging mechanism. So after an upgrade, it's very important to use revenue and usage and say, did anything change? And I'd use revenue and usage. I'd take 6 months and get the median on every one of them and start to see, did anything change? Because in a big upgrade, like an Epic to a bigger system, you need to run dual systems, and you need to be seeing they're coming out with the same revenue and usage. And if they're not, there's a problem. So they changed the process to where IT was responsible for refreshing it, and they automated it immediately after audit records. They continued the end sampling, and then they tested the new format. They further went back against the vendor and said, if you're going to disrupt a component of your software, you need to declare in the upgrade notes, you need to declare this could be disrupted. And so they started declaring potential failures. So they put some back on the software vendor. So this is an actual example of why audit and charge capture is so important. So as we sum up, and we've got plenty of time for questions and answers, you have to have the mechanism to create the documentation, and benchmark is going to be that the documentation is based, is going to drive the charge. CDM must be complete and accurate, and I'm going to tell you right now, the billing units in a CDM for pharmacy and supplies are your two areas fraught with errors in every CDM you go to. A mapping between ancillary systems has to be accurate. So here's another example that's not in the slide deck. I was quite young at the time. I'm not that anymore. And I was sent on my first job down to a hospital where the OIG was present, saying there was overpayment and there were ongoing concerns, and I was sent down to audit it. And what I found was they were doing approximately, and it was a very small hospital, less than 50 beds, and not very small, it was less than 50, and they were doing 400 angiograms a month, which was odd, and that's what the OIG felt. So when we did our audit, we found that the radiology information system had that as a 2-view chest x-ray, but when they mapped it to the CDM from the radiology information module, they accidentally mapped it to an angiogram, and unfortunately they never do angiograms in that hospital, so that was a problem. So the mapping is quite a problem. So when you do a new charge in a CDM, it is very important that part of your process with the new charge is you generate at least 25 stat bills and see that that charge came across correctly. Did it come across with the right CPT code? Did it come across with the right billing units? Is it something where there should have been a multiplier and the multiplier's gone off? So you really need to do those stat charges. The charge capture mechanisms must contain all possible charges, and charge reconciliation is key to ensuring the charges are captured. And we have one of two models, the concurrent 100% review, which the RI team monitors every day and then works the bigger patterns of behavior with the goal of alleviating the net revenue that you find in the system. You don't want to keep finding net revenue. That means you've got holes in your charge capture system. You want to decrease that to make sure that the revenue goes on the claim goes out the door clean, and your cash flow is enhanced. And then reviewing charges through a stated audit. I mean, every department should do it. IR is a big one, and Cath lab with all those first order, second order, third order vessels and supplies. And then remember, 1 to 5% is at risk. So your goal is to get it as low as you possibly can for your charge capture. So Dusty, I'm going to open it up to questions now, if you can assist us.
Yeah, no, that was awesome. A ton of information there, obviously. So we don't have any questions yet, but I'm sure people were just trying to keep up because you had it packed full of ideas and tips and everything. So again, the Q&A panel, please click into that, and we will stay on here a little bit. If anybody has any specific questions, now's your chance to get some free answers from Bill. While we wait for those as well, I just remind everybody that yes, we do send out a copy of the slides as well as a link to the recorded webinar. Actually, both those things live at the same link. We always do that. You can go to our webinars section of our website underneath resources, and all of our on-demand webinars and future webinars are there as well. Looks like we have a question pop up potentially. Someone just wants to see the last slide one more time, if you can show that.
Yeah, I tend to go fast.
Yes.
All right, so basically the charge capture includes documentation. That's the first step. So when you're looking at that blue 4 boxes at the beginning, documentation's there. You have to have documentation either in the record somehow to assess the charge. And the reason for that is the Social Security Act that said you cannot expect reimbursement unless a benefit category is achieved. So all payers follow that same methodology. Unless you achieve a benefit category, meaning it's a medically necessary service, and there's certain criteria around a benefit category, you can't expect reimbursement. So if you don't have the documentation, you don't have a benefit category, you can't achieve one, so you shouldn't be seeking reimbursement. The second set is the CDM and charge entry. Those are the purple boxes, and the CDM must be completely clean, but what most CDM people fail to recognize at times, as a general rule, they know it, but at times they look at it and they're like, I didn't check the mapping. That's up to IT to check the mapping. Well, IT shouldn't be the one because they don't know the procedure and they sure as heck don't know the CPT code. So what you need to do is go through the mapping, get a mapping report from the radiology information system, and then compare it with your CDM. Are those print numbers or are those CDM numbers in the radiology information system the ones you should have? Are there any mapping errors? So every year I get a report out of most of the systems and say, I need a report of the mapping. What is the, and there are fields that you put the CDM number in, or a print number or some sort of conversion number to be able to get it over the CDM. So mapping is essential, and that should be a revenue integrity job every year. Every year with year-end changes, obviously in November and December, you probably don't want to do it, but 1st of January, you need to take these reports, and maybe you have a revenue integrity person that does radiology, and maybe one does ED. Go ahead and get those out of the modules. Look at your revenue and usage. Has it changed year over year over year? Look and see. One of the things that I always audit, always, if I have a downtime that lasts longer than expected due to a system failure where they had to reboot or whatever, I automatically look on those days and see what happened. Frequently, the charges won't go through because there's downtime, and then they're going to batch process a bunch of days at once, and it's going to create havoc. So you want to look at that. And then the department, you can't expect to do charge capture unless you work with the department and understand what they're doing. So as a general rule, I'm not creepy or anything, but I go and stand next to the nurse in the ED for a day, or I stand next to the radiology techs, excuse me, and I look and see what are they doing and how are they putting stuff in. Some of them, in the old days, when they turned on the machine and the MA, they could pick it out in radiology. They could do it. They could assign the charge before they even did the test. Now it's done usually on leave department or on report. Dusty, other questions?
Yeah, we had some more come in, and someone did ask. I meant to mention this too. There are not CEUs attached to this. We asked Bill to do this pretty last minute, and so we couldn't get approval for any CEUs before that, unfortunately. But we do have another webinar tomorrow around COVID-19 billing questions that do have a CEU attached. So make sure to check out that one if you're looking for CEUs. All right. With that said, yes, we do have some more questions popping up here. Someone asked, are there generic audit programs available for charge capture audits?
There are different vendors. We're one of them that create charge capture programs. As far as generic, there really isn't. You can create, there are some generic templates out there for charge capture audit through a number of different vendors that just say, you know, pick the nth one or whatever. So there isn't really a generic. I frequently create programs specific to the department. So if I know that I have a department or during hospital mergers where I now have 2 radiology departments that are operating differently and I'm trying to come to a corporate baseline, I'll create an audit. So the audit is specific to the event, but the charge capture ongoing review can be software or it can be an nth method. And you can ask your audit teams. Auditors may have a hard time if they're internal getting down to how to create an audit program for a charge, but they're pretty good at helping you. And I would reach out to them. Dusty?
Someone's giving you some good compliments, a lot of good information. I agree with that. They'll be looking at the CDM a bit differently now. Should the compliance department be performing an internal charge master review annually or at least every couple of years?
I don't know that I would relegate it to the compliance department. It should be on the compliance work plan for the facility that a CDM review is done in writing with findings yearly. I tend to do them in April when the dust settles, because as we all know, if you get the OPPS final rule, it's a wee bit of fiction in January, and they change it up in February with all these amendments. So I kind of wait till the OCEs are out and what have you. But I recommend a written actual audit using key areas. So high dollar claims, looking at room and board. I find room and board, it's a real easy thing. And what's happening is they're finding in the scrubber that the room and board is 1 day longer then the patient was there, remembering that you don't charge the day of admission, you only charge for the day of discharge. So you're always 1 day short on room and board. You never charge the day of admission, you charge the day of discharge. So your scrubbers on the bill will find it and the billers will fix it. And that's one of the areas where I find real failures and feedback is the billers go through and they got to get stuff off the claim. And what I find is even though billers are instructed to never, ever, ever, ever take anything off the claim, they do. And so I find a lot of lost charges because something's not going through. They have a work queue. They either throw a 59 on it when no 59 is appropriate, or they change the units to 1 because it exceeded the MUE instead of understanding how to process that. So the charge capture, but the billers seldom give back. So what I always have the charge master people do quarterly with the audit group and revenue integrity is meet with the billers, the lead billers, at least once a quarter and go through their findings, go through their denials, go through what the payers are asking for when they are asking for more information. You know, they want more medical records. Why? So I do that quarterly, but the CDM should be audited real time and yearly.
Great. How many of the hospitals you have visited in your career have a non-clinical charge capture team to audit all clinical charges? What have you seen? Is this more of a concern in today's health systems?
Due to analytics, I find more and more there are more analysts, data analytics, than they really are clinicians. Back in the day when we did more manual, it was like nurse auditors and things like that. But with the use of analytics and the use of databases that tell us what those codes are and what the relationships are, and the fact that HIM generally has a coding specialist assigned to outpatient and inpatient, I'm seeing more and more either a blended model or where there's more analytics and then the clinicians do the defense audits and they look for it. I mean, when I was director of rev cycle at an integrated delivery system, I had 25 analysts and 3 nurses. And we were able to breeze through with the nurses because they were more of a check. So it really depends on what you're trying to do. If you're in an institution that does very complex procedures, maybe you're doing a lot of research study, maybe you need more clinicians, but there's really no right answer to that. You can do anything.
Great. Again, excellent presentation. Thank you. Any recommendations on how to audit implants? They are usually massive in quantity of items and very difficult to accurately identify the type of item. HCPCS are sometimes not clear enough.
You're absolutely right on that. And what I tend to do, and this is not a vendor-specific presentation, but if you do have vital knowledge, I go into devices and I look up the model number. When I audit things, I start with my database, my data elements being the implant log. I then take that implant log, which by law has to have the model number on it in case it's recalled. I go either to the vendor site and see if a code's assigned to it, or I go into knowledge and see if a code is assigned to it. I frequently see C codes being assigned to things for which no code has been assigned by the FDA or the government, simply because there's a thought. What is it? A bone screw is a frequently missed one. C1713. That one is free. It's very much an attachment. So I had to look up the other day, and there's a type of bone screw that's actually a suture type. So that just got FDA approval as being a bone screw. Joint devices, is that really part of the joint device? So I have seen cement for the joint with C1776 on it. If that's not a joint device, that's cement. It's a SU72 without a HCPCS code. So I see a lot of things happening. The quickest way is to go to the vendor. The other thing I'm making a lot of times when I was the revenue integrity director is I made supply chain get the vendor to put the C code, if one existed, or the L code, if one existed, either on the package or in the invoice. And we would not pay the invoice until we had the code. So for those vendors that pop in, and they're on contingency and they bring a suitcase full of stuff you may not have in the CDM yet, those codes have to be there. And so pushing back on your supply chain. The other thing I find, and this is not a negative towards any manufacturer of software, but those software groups, those software technology used in hospitals that use shells, I find erroneous things in those shells all the time. I was at one hospital that had $7.5 million because the shell, everything linked to 272, and they were all device carve-outs, 278, and so they were not getting paid by any of their proprietary commercial vendors because they didn't use the carve-outs. So those shells are always an ongoing issue. So you need to see say there's, I'll use the name Lawson just as a general term. Lawson has a model number in it, and that model number matches the implant. Did it match the C code of what the manufacturer said? So it's really time consuming. I am seeing more and more because implants and supplies are becoming such an issue. In the larger facilities, I am seeing a supply-only revenue integrity auditor that does nothing but check all these devices in and puts them in the CDM. So it depends on how much you're losing.
All right, we'll probably have time for only one more here, and then we'll have to get going. But Bill, can you see all the questions there? I'm not sure if there's a particular one that you think makes the most sense or not. Otherwise, I can pick one for you.
Is it from Cindy or Amy?
Yeah, Cindy. So,
okay, for Amy's thing, yeah, they can't provide coding guidance, but you can call up the vendor if you're buying stuff from them. They have a reimbursement department, and they will send you out lists of likely codes. If it's Medtronics, they publish them all. So for Amy, yeah, that's a known issue. Cindy, how do you audit for claim edit denials for different payers, especially? So I go in, Cindy's question is, how do I do payer edits? And because they have different codes, and Medicaid is the best one. If you're on Medi-Cal, that's even a more dodgy thing where they have their own set of codes. But generally, I will go in, I will look at the CDM and making sure that they have the right code per payer. Remember, the CDM can have alternate codes and alternate column, and looking to see, is that the right code? I frequently see the CDM team focus on Medicare and totally forget about the other payers. And so when you go in there and you see that the alt code isn't correct or it's outdated, and you'll find it. So the deleted codes from level 3 HCPCS codes, like your X's and all that you see with Medi-Cal, they delete them like 7 years after everybody else has, and they just quietly do it. So I have to go through their fee schedule and look. So that's just kind of an arduous task to make sure that works. And Denise, thank you for providing the Excel formula.
Perfect. Well, we are out of time, unfortunately. There's a lot of great questions. We'll try to follow up with those that didn't get answered. Make sure you get those. But again, the recording and the slides will be up on our website within the next couple business days. If you do need to rewatch or refer a colleague to the presentation, we really appreciate you joining us. Again, we do have another webinar tomorrow on COVID-19 billing and coding FAQs that does have a CEU attached to it. So please register for that if you can, and we will talk to you tomorrow. Thanks, everybody. Have a great day.
Thank you. Bye-bye.